Well, thank you everyone for joining us this evening. I'm so excited for our lecture program entitled OCT and OCT Angiography in Clinical Practice by Dr. Julie Rodman. Next slide, please. And I'm your host and moderator for this evening, Dr. Carolyn Major, an associate professor and the director of residency programs at the Oklahoma College of Optometry. I want to give a special shout out to Zeiss for exhibiting and sponsoring this event. It couldn't be possible without them. So thank you so very much, Zeiss, for sponsoring this. And just a few friendly reminders before we get started so that you can all get your CE credit. For each hour of CE credit, you need to be online for a minimum of 50 minutes. For a COPE certificate, you need to make sure that you fill out the survey link in the chat at the conclusion of the program. Also, the survey link will automatically pop up once the webinar ends. CE certificates are going to be delivered by email and sent to ARBO with OE tracker numbers. We'll also display a QR code at the end of the session that if you have the OE tracker app on your phone, you can go ahead and use that to also obtain credit. And CE certificates will be emailed within 4 weeks. And please ask questions throughout the program because we're going to have a Q&A at the very end. So you can ask questions by using the floating Q&A panel down at the bottom. Next slide, please. And if you're using your phone, you can also ask questions by using the Q&A at the top of your screen or down at the bottom using the little dots. Next slide. And it is my absolute pleasure to welcome our speaker and my dear friend here this evening, Dr. Julie Rodman. She is the chief of the Broward Eye Care Institute in Fort Lauderdale, Florida, and a professor of optometry at Nova Southeastern University. She's also the instructor of record for the posterior segment disease course at the college. Her research interests include OCT and OCT angiography and vitreoretinal disease. She's authored over 30 publications with an emphasis on retinal disease. She recently published Optical Coherence Tomography Atlas, a case study approach, the first reference book on this topic written by an optometrist. Dr. Rodman is a member of the AOA, AAO, FOA, and ORS. She's been the recipient of numerous teaching awards and recognized as Primary Care Optometry News Top 300 Optometrist and Newsweek Best Optometrist of 2022. It was my absolute pleasure to welcome you here this evening, Dr. Rodman. Thank you for joining us.
Thank you, Dr. Major. It's always so much fun to have you on the screen next to me. So those are my financial disclosures. All financial relationships have been mitigated, and let's get started. So I'm always very, very excited to be on Wu University, but I'm particularly excited tonight because I'm talking about one of my favorite topics, which is OCT and OCTA in clinical practice. You know, this has been a really, really amazing year for OCTA, or I should say 2025 is going to be, because there is now a CPT code for OCTA. So we can actually get reimbursed for the time and energy that we take in interpreting the scans. So hopefully that excites and energizes a lot of you. All right, so here we go. So in order to understand OCT and OCTA, you really have to be familiar with retinal anatomy. So I want to take just a quick minute to review some of these important landmarks on the retina, and then we'll kind of talk about how you can transpose this onto an OCT scan and how you can transpose this onto an OCTA scan. So when you're looking at the retina, some important things to keep in mind. The vitreous is our most superficial part of this kind of vitreoretinal analysis. The inner limiting membrane is our most superficial layer of the retina, and it's very important because it separates the vitreous contents above from the retinal contents below. And then we have kind of what I like to call the sensory retina, which is really everything from the nerve fiber layer all the way down through the outer or external limiting membrane. And the very cool thing, which we're going to see on the OCT scan on the next slide, is that kind of makes it easy for us. We always have a plexiform layer before a nuclear layer. So our inner plexiform, inner nuclear, outer plexiform, outer nuclear. Then we have our photoreceptors, our RPE, which we know is very, very important because it separates our retina from our underlying choroid and keeps the choroidal contents, which are essentially blood, out of the retina and really forms the tightest blood retinal barrier that we have. Brooks membrane is somewhere in here, which is hard to see, but I'll show it to you on the next slide. So when we look at this on an OCT scan, it's essentially taking that retinal anatomy that we just had and transposing that onto what we call this OCT-B scan. An OCT-B scan is almost like if you took a cake, a layer cake, and cut it down the middle and then opened it up, you'd be able to see all the different layers. So that's essentially what we're doing here on an OCT-B scan. This black space on top here is our vitreous. Again, we know that in most patients, our vitreous is not going to be clear like that. There's going to be some type of, white hyperreflective thing floating around in there. That's normal as we get older. We have our hyperreflective band, which is our inner limiting membrane. And again, the most superficial layer of what we call the sensory retina. And then, as I said before, we have these layers that kind of alternate in reflectivity. OCT is based off of reflectivity. It's how each tissue reacts to light, kind of these light beams coming into the eye. So we have our inner plexiform, which is hyper, and our internuclear, which is hypo. And then again, same thing, outer plexiform, hyper, outer nuclear, hypo. So really kind of easy to explain or easy to interpret. The other thing that you'll notice on top here is that the nerve fiber layer takes on this triangular hyperreflective appearance, followed by the ganglion cell layer. This is where our axons of our ganglion cells and cell bodies of the ganglion cells live. And this exits out towards the optic nerve. So wherever you see this hyperreflective wedge, that's the side of the eye that, that you're scanning. Underneath our sensory retina, we have our external or outer limiting membrane, which is this fine powdery line. And then we have this very important boundary here, which is it's our photoreceptor line. There's many, many names for it. It's been called the PIL, or the photoreceptor integrity line, the IS-OS junction, which is the inner segment, outer segment junction of the photoreceptors. It's been called the ellipsoid zone. But really, this is a super, super important landmark, because if patients have any type of disruption in this photoreceptor integrity line, vision is going to be compromised, particularly if we're looking at the central part here, right under the fovea. Under that, we have our retinal pigment epithelium with an interdigitation zone, kind of like peanut butter and jelly in a little sandwich form there. Then we have Bruch's membrane, and underneath we have the choroid. These darker areas within the choroid are our choroidal blood vessels. So, being familiar with these layers on the OCT-B scan is very, very important. Again, once we start learning OCT angiography in particular. The other important word to keep in mind when you're learning OCT is an en-face or on-face cut. So remember, I just said a B scan is if you were to take a knife, cut a cake, and open it, you'd be able to see all of the different layers of the cake. A B scan is essentially, an en-face cut is essentially a horizontal or C cut. So what you're doing now is you're actually visualizing or cutting through vasculature. So en-face cuts can be structural, meaning you can see them just like a flat view, like what you're seeing here. You can also look at them 3D wise, where you can actually visualize the vasculature, which I'm going to show you when we learn angiography. So when you look at an OCT cut or OCT scan, the right way to do it is to always look at an OCT-B scan side by side with an en-face cut. So what you're seeing here on the bottom of the screen here is you're seeing your B scan with two lines. And this is the area that we're actually visualizing on the en-face cut above. The green line being the anterior portion of it, the red line being the posterior portion of it. And it goes on as we get deeper through the eye. And you'll notice how the vasculature, again, kind of changes as you're cutting deeper and deeper through the eye. So, B scan and en-face cuts really should work together to give you excellent visualization of the retina and choroid. Okay, so I mentioned before angiography. Angiography is based off of these en-face cuts. So let's talk for a minute about where this fits into the picture of OCT. So back in the early 2000s, time domain OCT was introduced, and this was huge in the field of optometry, ophthalmology, because really for the first time we were able to visualize in a non-invasive way the structural part or the structural presence of the retina. The problem with it is that there were a lot of pixelations, questionable artifacts in the scan. So a couple of years later, the companies came out with spectral domain OCT, and the beauty of SD-OCT is you get more cuts or more A scans per second, allowing you to have higher resolution, better visualization of the retinal layers, taking away a lot of that questionability of, is this an artifact? Is it just poor image quality? The problem with just OCT on its own, as much as we all love it, is that it doesn't allow us to visualize vasculature. It is essentially a pure view just of structure. So a couple years later, the OCT companies got together again and said, how can we do something? How can we make a technology where we could visualize vasculature in a non-invasive way? And so then OCTA was created. And you'll see that OCTA here looks very different than OCT scan. It looks more like the ONFOS or the angiography. I'm sorry, the ONFOS images that I showed you on the previous page. So, questions really that I've heard during the course of my time learning OCT angiography is, why do I need this in my practice? And I would argue that if you want to take the best care of your patient and identify things early before we see them clinically, this is the technology to allow you to do that. If you want to manage more pathology, keep more things in your practice, this is the pathology to help you do that. I would also argue that you want to go to a doctor that has the best technology to take the best care of you. So, to be the doctor on that street that has this, I think is really quite important. So just to reemphasize, your OCTA is amazing at looking at structure. It's non-invasive, super easy to perform, but remember, we cannot visualize vascularity or flow. So in the good old days, we would have to send out for fluorescein angiography, for indocyanine green angiography, if we had a question about whether or not the patient had some kind of lesion that had to be visualized with one of these tools, because we couldn't do it in our own practices. So now with OCTA, how does it work? So it's essentially a motion contrast system. What it's doing is it's using sequential B scans to look for irregularities or differences that really equate to motion. So what I mean by that is what the machine is doing here is it's taking sequential B scans. Depending on the machine that you have, it might take 2, it might take 4, it might take 5, but it looks at subtle differences in reflectivity between the B scans. When we look at these, the naked eye, they look identical to us. However, there's an algorithm that is able to get into the nuts and bolts of the scans and really look for any very, very subtle differences. Again, using this kind of motion contrast system to evaluate for blood flow. So what they're doing here is they're saying whatever looks different between these two scans has to be blood, because the only thing in the retina that's moving is blood, is red blood cells. So from these two images, they create what we call a flow overlay image. Most technologies use different colors, but the bottom line here is that wherever you see flow, wherever you see pixelation, that is where the technology said, there's something moving there. There's something different between my B scans in those locations. It makes sense that you should see pixelation within the inner retina or the sensory retina, because that's where all of our capillaries lie. It makes sense that you should see pixelation within the choroid, because again, that's a huge powerhouse of blood. When you begin to see pixelation in areas like the RPE, which is an avascular space, or the vitreous, which is an avascular space, that's when you should start asking yourself the questions of, why do I see flow there? That is when we're going to begin to pick up pathology. So in order to really assess OCTA properly, you should be looking not only at the angiogram, but also at the flow overlay image. So you may be asking yourself, how do I get from point A, which is here, to point B? So essentially from this flow overlay image, on-phos cuts, coronal cuts are taken through the B scan. And this is allowing us to visualize vascular supply or vascularity at every layer through that B scan, through the retina. So if you look at it in a little bit of a different fashion, if you were to take the retinal anatomy and you were to take on-phos cuts, again, through the retinal anatomy, you're going to be able to evaluate for the blood flow to different areas. So if we were to look at the most superficial blood flow to the retina, we're looking at what we call the superficial capillary plexus. Depending on your technology that you're using, this may vary as far as which layers are included, but what you should know is that you're looking at the vascular supply to the most superficial part of the retina. So what you're seeing here is the blood flow. All the blood vessels are highlighting here what's feeding this area. The center should be black because that is the foveal avascular zone. So anywhere on angiography that's black means there's no flow. Sometimes that's normal, like in the FAZ or the foveal avascular zone. As you move more posterior, you're going to hit the deep capillary plexus, and you can see how the blood vessels change both trajectory, size, and course. You keep going more and more down, you're going to hit the area around the RPE. And remember that the RPE is an avascular tissue. So it's 100% normal that this slab should be black. The most posterior layer is going to be the choriocapillaris, which is, again, a very saturated, dense blood area. So you're going to see a white, homogeneous type of, appearance to that. So understanding these slabs and what you're visualizing is important. It's also important to understand that you can make as many slabs as you want. If you wanted to visualize the vitreous, you could move your en-face cut higher up. Some technologies actually provide you with a vitreous slab. It doesn't matter. You can make it if it doesn't come automatically. So just to reiterate, very important to look at the angiography alongside the flow overlay image, because what you want to look for, again, is differences in flow, and you're going to be able to see that on the flow overlay image. So we're going to go through lots of examples throughout this. I'm going to try to move forward, but some important points once again. If you're looking for structure, drusen, fluid, elevations, disruptions in tissues, anything structural is going to be B-scan. Anything vascular is going to be angiography. So if you're looking for too much blood, like a CNVM, or not enough blood, poor perfusion from a vascular occlusion, that's going to be OCTA. I don't want to spend a ton of time comparing fluorescein to OCTA, but some of the important points to pick up here, again, OCTA is non-invasive. You don't get as wide of a field of view as you would with fluorescein, but this is getting better and better with time. The machines are giving us more than they used to. Very, very high resolution with OCTA, and I'm going to actually show you how in some situations you can actually even see more with OCTA. One of the downsides of OCTA is that because it's a motion contrast system, if the patient is moving a lot or jumping around, that's very, very hard to scan. So you need a patient that's cooperative and sits still. OCTA does a beautiful job with segmentation. I showed you before. You can segment down to the micron, which you can't get with fluorescein. And one of my, biggest things with OCTA is it's fast. You can image a patient in a couple of minutes, probably less in a cooperative patient, where in fluorescein, you could be there for upwards of 30 minutes. So here's some really beautiful images that you will see with OCT angiography. They come in all different sizes. The important thing to remember is that when you look at the numbers of scan selection, you're looking at a horizontal by vertical. So 6.4 times 6.4 means you're going 6.4 horizontally, 6.4 vertically. You can do 9s, you can do 12s, you can montage and make big, big ones. And keep in mind that it used to be when you got these huge images, you would lose resolution. Well, that is no longer the case. You can see here that the resolution of the images is not compromised at all, despite a larger and taller field of view. So what I want to do, because I think this is what most people care about, is show you how we can clinically use OCT angiography in practice and how it can make you a better clinician. So I have a bunch of examples through this presentation. It's mostly cases which I feel like are the most effective. So I want to start off with, just to go back here, intraretinal disease. When we talk about OCT angiography, we split the retina really into two quadrants. We do inner retina, which is going to be the superficial and deep plexus, and then our outer retina, which is going to be our avascular zone and choriocapillaris. And I'll go into that, you'll see in just a minute. But it's important to remember what diseases affect what part of the eye. Otherwise, you're not going to be able to accurately interpret OCTA. So when you're looking at intraretinal disease, just to reiterate, an intraretinal disease means a disease that's affecting the sensory retina, like diabetes. Diabetes is the number one thing that affects intraretina. You're looking at the superficial capillary plexus, which I showed you before, and the deep capillary plexus, because those are the two plexi that feed into the sensory retina. So on the top right, I have normal, right? That's our control. That's what I showed you guys before, what the vascular supply looks like feeding into the superficial and deep. What are we going to see in patients that have diabetes? So a couple of things. The yellow arrows here are pointing to little microaneurysms. And so what that is, little capillary outpouchings. Remember that in microaneurysms, the blood is still inside the blood vessel, so it's able to be imaged with OCTA. Remember that once the blood exits out of the blood vessel, OCT angiography will no longer image it because it's only picking up movement in the blood vessel. So microaneurysms, it does a nice job with. The red arrow is showing you capillary non-perfusion. Remember, black on OCTA means no blood flow. So patients that have diabetes have these kind of sectoral areas where there's no perfusion. That's what you're noticing there. What you want to see is this homogeneous type of appearance where there's no areas where there's loss of perfusion. And really, the last thing that you should identify here is that the foveally vascular zone looks large and irregular. That's because there's all of these areas around the FAZ of non-perfusion. So that makes it look more anomalous and misshapen. So, give you an example here. This is a 45-year-old African-American female who tells me that, her blood sugar is excellent. She doesn't know the number, but she's proud of her A1C at 7. And in my clinic, an A1C of 7 is outstanding. So when we get fundus photography, it looks really pretty good. She may have one or two little MAs there, but nothing substantial. Her OCT-B scan looks fabulous. There's really no retinopathy there. And I rewind to the days before OCT angiography and what I would have told this patient. And I would have said to her, "You're doing amazing. This is a patient that I would have seen in a year, would have communicated with the primary care physician and said, she's doing a great job on whatever she's taking." But introduce 2022 or whatever, whenever I go to OCT angiography, and I do this now on my diabetic patients because I find that it really helps me to preemptively diagnose things that I don't see clinically. And so I get OCT angiography, and you can see here that this patient has a lot of these findings that I just explained. She's got a lot of areas of capillary non-perfusion, enlarged in the foveally vascular zone. She's got some microaneurysms. And so really the home message here, the take-home message here is that education in these patients is really crucial. So if we're telling the patient that they're doing great, then they're going to go home and continue the behaviors that they're doing, whether it means eating a pint of ice cream at night or sitting on the couch not exercising. When these changes are brewing, being able to tell them early on that they have this, I think, makes a big difference in the trajectory of their disease or the course of their disease. So it's all in how we educate the patient. So this is what we don't want to happen. Let's say that this was what her OCT angiography looked like when I saw her, and we didn't have OCT angiography, right? So she went on and continued her behavior. And then she comes back a year later, and this is what she looks like. And this is just horrendous, right? This is a patient that has developed significant capillary non-perfusion and is probably going to go on to develop proliferative disease in a short amount of time. So once again, understanding the role of how OCT angiography can change the course of the disease. This was a 45-year-old glaucoma suspect, a diabetic of 5 years, with a history of poorly controlled blood sugar. And he tells me that he's had trouble with every medication that his doctor has put him on. His current vision is 20/25 minus. And, again, you look at the photo here and it looks pretty good, right? There's nothing there that's really concerning me. But what I was asking myself is, if he's 45 and he doesn't have cataracts, why is he 20/25 minus? And unless you have a good reason behind this, unless he has significant glaucomatous disease or something, it's really on us to try to figure out why that acuity is decreased. Bring in OCT angiography. Again, I'm just highlighting that this looks completely normal to me. Bring in OCT angiography, and you'll notice here that this patient has this enlarged foveally vascular zone. And what this really equates to is something called macular ischemia. And we've known about macular ischemia for many years, but with the advent of OCTA, it has become much more prevalent. And macular ischemia is really defined as this lack of perfusion to specifically the foveally vascular zone, the foveal zone, which is resulting in decreased acuity. And the unfortunate part about macular ischemia is that it doesn't respond well to anti-VEGF because we're not treating a vascular source. There's really no perfusion here. So this is something that we have to take very seriously in patients because there's really not a good resolution to this problem. Just another example of a similar thing in a 55-year-old African-American male who had no clinically significant diabetic retinopathy. We didn't see anything fundoscopically. His vision, though, was 20/50. And again, I pose this question to you, if you had a 55-year-old who came in, they were diabetic, and you didn't see anything clinically, you didn't see anything in their lens, no reason, nothing on their cornea, nothing that equates to this vision. how would you proceed? Are you going to sign off on a chart without being able to explain why the patient is 20/50? So OCTA really comes to the rescue in many of these cases, because once again, this patient, even worse than the other one, has significant macular ischemia, large microaneurysm here, but really understanding the importance of where this fits in the management of this patient. So yeah, we're going to refer this patient certainly, but what is the resolution going to be? Is the patient going to have a good outcome? I don't know. I don't know how good the outcome is going to be because anti-VEGFs don't do a great job. I mentioned before that OCT angiography sometimes gives you better resolution than regular fluorescein. The reason being OCTA, again, does not image anything leaking out of the vessel. So because you don't visualize leakage on OCTA, it could be good or bad. But when you're looking at resolution, because we don't have these leaking microaneurysms, because we don't have areas that are going to block good visualization, you can actually get excellent resolution here compared to the fluorescein. So sometimes OCTA actually gives us better understanding of a disease process than a fluorescein might. This was a diabetic patient who had extensive PRP done and also had reduced vision bilaterally. And I'm just going to show you just another example of looking at a patient, trying to understand why is this patient's vision decreased. This is the OCT angiography. So I think I've already driven home this point. PRP is a destructive mechanism. It causes, poor perfusion and ischemia to the retina. So this is another patient that suffered some consequences that maybe you wouldn't have been able to see. And this is the other eye without this technology. This was a great case that I had to actually reach out to a colleague about because I really wasn't sure how to interpret what I was seeing. I had just gotten OCTA. This is a 50-year-old diabetic female. She has had diabetes for 10 years. Let me move this to see her A1C was 5.9 with visual acuity of 20/20 in both eyes. And like I told you, I started running this on, if I can, on most of my diabetic patients to get more information about what's happening. And I blow up here the foveas just to show you that if you look very closely, you'll notice that the patient has these very fragile, anomalous vessels in both eyes surrounding the fovea. I was like, wow, that's weird. I'm like, what's going on there? The rest of the retina looked pretty clean to me. So I wasn't really sure what I was seeing. So I went ahead and did OCTA, and this is what I found. And this is an OCTA of the superficial plexus. And she had all of these really, anomalous little kind of fine vessels, maybe a few capillary outpouchings. And so I reached out to, and I was just learning OCTA. I reached out to one of my friends at Tufts who actually trained me on the technology. And she said that this patient has these parafoveal or perifoveal microaneurysms. She said there's just extensive microaneurysms going on there. And this really highlights what, maybe we couldn't see clinically very well. There's also a lot of areas of capillary non-perfusion. Understand, just to go back here, this is a patient that has no clinically visible retinopathy, except for what's happening in the macula. So you ask yourself the question, what is going to happen with this patient over time? This is the deep plexus. Again, look at the B scan, completely unremarkable. There's really nothing to talk about here on the B scan. And this is the other eye, just this extensive abnormality in the foveolae vascular zone, which are these paramacular microaneurysms or capillary outpouchings. And then I have the deep plexus here as well. I find these cases fascinating just because there are things that I certainly wouldn't have had great answers on without this technology. We also have the ability to look at patients over time. So here's the patient when I saw her in March of 2022, and I brought her back a couple of months later to just reassess. And what I found interesting is that despite the fact that the foveal avascular zone looked similar, if you look at this little area right over here, look at how much more capillary non-perfusion there is in just 2 months' time. Is this a reflection of the scan? The scans look like they're good quality. I don't want to blame it on the scan. So you really ask yourself, if this patient's rapidly progressing like this, what are we going to see in 6 months' time? And this is just the other eye showing you similarly what can happen over time. Here's yet another patient that is a train wreck, right? A 62-year-old Indian male, diabetic of 20 years with very high blood sugar levels with a recent decline in vision in the right eye greater than the left. And, you look at this and you don't know where to begin. And I would argue, and I bet a lot of you agree, that it is so hard sometimes when you're looking at patients to identify, is that proliferative disease? Is that IRMA? What exactly am I seeing? And there are so many times that I rely on angiography to help me make a good decision about referral patterns and how long I'm going to hold on to a patient for. So I just wanted to kind of break down these a little bit to show you what we were looking at. So this is the right eye, beautiful image, so much stuff going on. It looks almost like there's a lot of abnormal retina here. Maybe this is proliferative disease. Down here, there's abnormal vasculature. There's tons of exudate. I don't even know where to begin, right? But I went ahead and got an OCTA scan because I find that it just cleans everything up for me. I'm able to look at it in a different light. First thing I want you to appreciate is that on the OCTB scan, you'll notice that there's this area extending into the vitreous here. There's red or flow running within this area, which is an indication that there is active blood vessels or blood flow within this. We all know there should not be anything up in the vitreoretinal interface. There shouldn't be anything up there that has blood in it. That is telling me that there is neovascularization. So then I go ahead and I look at my angiography next to my B scan with flow overlay, and I can see here this whole area is neovascularization. Notice there's all this capillary non-perfusion surrounding the neovascularization, which is where we usually see neo, right? We usually see neo with areas of capillary non-perfusion, usually adjacent. There's also other areas throughout this of anomalous vasculature. This is the other eye, doesn't look as bad as the right, but yet what's happening in this area over here? Is this proliferative disease? And once again, looking at my B scan, you can identify that there are these areas of pixelation at the vitreoretinal interface that should not be there. There should be no blood flow, no pixelation, no vascularity in the vitreoretinal interface. Look at all of these neovascular fronds. So this just, again, helps to really solidify what maybe doesn't look so clear clinically. Another diabetic patient here, I'm going to fly through this because I want to get to some other stuff, but this anomalous area here, did angiography, look at that. I mean, it's just amazing to me the things that this machine can do. I mean, it picks it up for you, it yells out for you. This is a big neovascular front. And what's kind of cool about this patient is that there was nothing going on otherwise on the retina. This was such an ischemic eye that there literally was this one pouch of neovascularization, which is, confirmed right there. And there's just other ways to look at it, which I'll skip over. I'm going to skip over these slides because I want to get to the rest of the presentation, but just so many images here of proliferative disease. This shows you how I mentioned before that OCTA sometimes does a better job than fluorescein at identifying things. Remember, fluorescein is going to, when you have neo, it is going to leak. It hyperfluoresces. This is a leakage defect. On OCTA, you can actually identify the neovascular frond because remember that OCTA does not show leakage. So really a nice example of that here. Just some vein occlusions. Once again, look at the capillary non-perfusion in the area of the vein occlusion, just showing you the amount of ischemia that this patient has. Here's another beautiful image. You're asking yourself, how much ischemia does this patient have? Can I use my OCTA to help me? And just look at the images. I mean, so beautiful. Yes, we should still get fluorescein. The gold standard is to assess for, 10 disc diameters of capillary non-perfusion. But this gives you just a nice idea of how ischemic the patient's eye is. I wanted to mention something called angioanalytics, which is a quantitative platform that can help us make clinical decisions when we're not sure. So instead of guessing, does my patient match the normative database? Does my patient have ischemia? This technology can allow us to look quantitatively at our tissue in different ways. We can measure the amount of flow, looking at flow area. We can measure non-flow. We can measure the size of the FAZ in a quantitative fashion. We can use color metrics to help us to determine how much flow there is. This is an example of how we can look at quantitative data in diabetic patients If you look at a normal eye, you can measure the size of the foveolae vascular zone. You can measure the perimeter. The machine spits out for you data. So if you were to look at the same patient over time, you can look at the size of the FAZ. And if it's getting bigger, then you know that this patient is getting worse. You don't have to guess, is my FAZ getting worse? And what you'll notice here is that, diabetic patients are going to have bigger foveolae vascular zones than control patients. But I like to look at the same patient over time. So here's a patient, over the course of 2 or 3 years, you can measure their FAZ. It started at 0.171, went to 0.241, and ended up at 0.305. This is showing you in a quantitative fashion a serial analysis of a patient and how they're doing basically not very well. This is, again, just showing you in a diabetic patient the different severity of the disease. Notice how much darker the scan is getting as the disease gets worse, because that is indicating capillary non-perfusion. This shows you no flow. If you're curious about a certain area, you can just click on it and it will highlight it for you and color it in for you and give you a quantitative measurement. Remember, you can use colors. The brighter colors mean healthier tissue, more tissue saturation, and it gives you a percentage scale. You can even break it down by quadrant and look at different quadrants to determine how different quadrants are doing over time. You'll notice that the mild has much more brightness, much more capillary density than a patient with proliferative disease. You can look at a patient again over time with a color density map. And this is what I was showing you. You can look at quadrants. Every quadrant shows you percent saturation. So if you're wondering, how's this patient's perfusion doing superior temporal, you can look specifically at that area. You can just look at colors if you don't want to get into it and just see that this is getting darker over time. All right, let's spend the last 15, 17 minutes looking at outer retinal disease. So I mentioned before that when we do inner retinal disease, we're looking at the superficial and deep plexus. When you're looking at outer retinal disease, you want to focus on the RPE, or avascular slab, and the choriocapillaris. So this is a great case of a patient that had a post-traumatic choroidal rupture. Remember that choroidal ruptures usually happen in this kind of arc fashion, either around the macula or around the nerve. And the biggest thing that we worry about in patients that have choroidal rupture is, are they going to develop choroidal neovascular membranes? Biggest risk factor, you're breaking down the blood-retinal barrier. You can use this technology to visualize the choroidal rupture and to see if there's any underlying bleed that would necessitate a referral. Because normally with a choroidal rupture, we can monitor if there's nothing going on. But take a look at this. Do we think this is good or bad? This is one of those that's on the fence. Are we seeing greenish gray here because we're visualizing choroid, or is there actually a bleed there? Beautiful image here of CNV, right? A CNV living underneath that choroidal rupture. This necessitates a referral. Just a nice picture of how this technology can help you to make good clinical decisions. This is a 65-year-old Caucasian male who had a history of dry AMD and was coming and complaining of this recent change in vision in his left eye, 20/40 in the right, 20/50 in the left. You break it down, you can see that the patient has these intermediate sized drusen. You get an OCT B scan and you can see these large drusenoid PEDs. OCT angiography tells us, though, don't worry yet about this patient as far as bleeding goes. Yes, there's some shadowing from these large drusen, but there's no evidence, at least in this eye, of any neovascular disease. The eye that the patient was complaining about, look at the OCT. The OCT has drusen. This one over here is certainly anomalous. And I always tell my students, if you see any hyporeflectivity next to a drusen, you gotta worry about bleeding. Where is that fluid coming from? When you look at the B scan, you can see that there's these flow areas within this drusen cavity. Why would you have flow within a drusen cavity, right? If you look at these drusen, they're clean, or this drusen. Why is this here, right? So remember, use your flow overlay. You shouldn't have flow within a drusen. Look at your angiograms. There is a membrane right there. And yes, there's some shadowing artifacts, but there is a membrane. So this patient was complaining about something, and you look at the photo here, it is unimpressive, right? There's nothing there that is yelling out to me that there is a CNV, but my flow overlay image and my angiograms helped me in this case to identify a lesion. This was a patient that likely had histo, right? Peripapillary atrophy, something funky at the macula, 20/25 vision, was told he had a history of dry AMD and he was a smoker. Here's his OCT scan. Does it look weird to me? Well, I don't know. This drusen looks kind of large to me. Is there irregularity over here? Hard to say. I'm showing you cases where I scratch my head and I said, well, I need something else to help me make my diagnosis. What am I going to do in this particular case? I put up here comparing, what a PED should look like. It should be taut. There should be no evidence of any fluid or disruption around it. This was this patient. Number one, you can see that it doesn't look taut, even though there's drusen inside, it should still be taut. There's the irregularity here. I got my flow overlay image, which I'll show you right there. It is filled with pixelation. It is filled with flow. This patient had a CNV. Imagine, right? This is not what we would have suspected at all. This technology helped make a good diagnosis. This is an obvious CNV, right? This is one where we don't need OCT angiography to help us, but I just wanted to show you that here is the membrane, right? Some great images. I love this patient, this case, because this was one that I totally would have missed. This is a 63-year-old African-American male. He came in for a glaucoma workup, right? He's glaucomatous. When we do a glaucoma workup, we get a GCC scan. What is a GCC scan? It's a retinal scan, ganglion cell layer, top 2 or 3 layers of the retina. So I'm looking at this and I'm like, okay, the horizontal cut looked fine, but my vertical cut looked weird because of this. And I said, what the heck is that? So I said to the student, let's get OCTA. We have OCTA. Let's figure out what that is. Is it just a drusen? Is it just a little blip? And I blow it up again because there's nothing there. And I found this little guy. And when I look at the flow overlay, I can see that there's increased flow in this area. Well, come to learn that this is called neon or non-exudative occult membrane. Essentially, if you break it down, it's non-exudative because there's no leakage on the B scan, right? There's no fluid like I showed you in that previous one where there was that black spot. There's no fluid here. So it's non-exudative. It's occult because it's living below the RPE, and there's a membrane. So we call that neon or non-exudative membranes. It's also known as a double layer sign. I can't tell you how many of these I have picked up using this technology that I never would have picked up before the advent or before I had OCTA. I probably would have called it an anomalous drusenoid area, and I would have monitored it. So another great example of where this technology shines. What about our high myopes? Our high myopes that are at risk of developing choroidal neovascular membranes, right? That's one of the things we look at. We have these great technologies now that allow us to get these wide field views where we can get the optic nerve and the macula in one cut, right? These huge views. Is this a CNV? Is it not? Hard to say. What am I looking at? Get OCTA. There it is. There's my membrane. So hopefully you're sitting at home looking at these pictures and thinking to yourself, what would I have done, right? These are all cases where I said, what would I have done? This is where the technology really has helped me to be a better clinician. Here's a patient, another one, choroidal neovascular membrane. Look at the pixelation right there. Don't miss it. That is flow within the lesion. This one is exudative. Here's all my fluid everywhere around the lesion. And there's the CNV. Another patient here, this is a patient that has what we call RP epitheliitis, just a very sick RPE, inflammatory. Again, it looks very shallow here. What's going on? The RP is lifted up. Look at the flow overlay image. Look at the increased flow in this area. This patient had a membrane. These are all examples of cases that are easily missed. I hope you're sitting there thinking, man, if I had that case, I don't know that I would have identified anything anomalous with it, right? So there certainly is stuff going on here that is easy to miss. This is another patient with, we did one of these wide field scans where we had the optic nerve head and macula in the view, and we identified this very anomalous area. I'm sure everybody could tell that this is a CNV. Just want to show you again. Here's the CNV. And what I wanted to highlight on this scan is that there's so many different ways that you can look at this. So you can look at it just looking at the outer retinal or choriocapillaris slab. You can get an en-face cut. Remember, I told you before that en-face can give you a structural view of the vascularity. You can also measure it. I mentioned before that we have these quantitative platforms now that you can just take your mouse and draw around the lesion and you can measure the size. And really the importance of that is if you're trying to show a patient, that you send them for treatment and they're like, I don't know if I'm getting better. I'm getting these injections in my eye. You can actually show them quantitatively over time how the lesion's doing. And once you track it the first time, it's very easy. The machine will kind of guide you on how to keep tracking it over time. This was a patient with geographic atrophy. And the importance of this slide is that before we had these really, really good OCTA machines, we were really only able to visualize a very small area right around the macula. Now, the larger, wider fields allow us to really get the full extent of the lesion. Look at the size of this geographic atrophy. This is not a choroidal neovascular membrane. This is visualization of the choroidal vasculature due to like a window defect, right? We have atrophy lifting up the RPE, lifting up the neurosensory retina, allowing us to truly visualize down to the choroid. I wanted to emphasize once again the en-face. You can beautifully image here this patient's GA. And what's cool about this is that this patient actually has a foveal sparing lesion because you can see here that this is healthy tissue. So different ways of visualizing this pathology allows us to see, and this is actually looks like it's a different patient, but this is foveal sparing here and looking at the en-face. And here you can see the angiogram. CSR is another one, just to kind of shout out to it quickly. Majority of times, we don't have to worry about CSR, right? We know that over time, these lesions will go away. We don't worry about it. However, what happens in the situation when they don't go away? So the easy one is this guy who's got this sensory detachment. Everything looks normal on the flow overlay. There's no areas of increased pixelation. You have a big shadowing defect here, but no evidence of vascularity. But the tricky one is when the CSR doesn't go away. And when it lingers, we worry about it turning into a membrane. So here's a patient. Again, look at the flow overlay. Look at the increased flow here under the RPE. That should not be there. Here, this is normal, flat. Look at this one. Look at the difference. This is a membrane. This happens to have been there for a while, but this patient has a membrane. Vitelliform, right? Vitelliform lesions, these big lipofuscin lesions in the macula. The problem with vitelliform is that they could hide bleeding. When you do a regular B scan, vitelliform lesions are going to image like this. You're going to get this big hyperreflective mound at the macula. Well, what if there was bleeding there? How would we know? How would we know that this was not just the lipofuscin that's hyper reflecting on the B scan? Use OCTA. This is a normal one. This one doesn't have any bleeding. This is just masking. This is shadowing. But look at this one. Is this one normal? Right? Another vitelliform. This one has a membrane hiding underneath it. Any patient now that I have vitelliform, we get quite a few of them, I get OCT angiography on because some of them, this one here, okay, this one was fine, right? And I'll also emphasize that because this hyperreflective area doesn't look homogeneous, there's kind of two levels to it, I would put money on it that there was something brewing under this lesion, but there wasn't anything. And this one, God knows, it looks weird. This one had a membrane. And I want to end the lecture with this slide because this is one of my favorite slides. I have 3 scans here that look anomalous, right? There are 3 OCTB scans. All of them don't look good to me. And looking at them, and I already have the answer up here, so it's not really a quiz, but ask yourself the question when you look at the B scans, which of these would you have been worried about? A, B, or C? A looks like just intermediate AMD. You know, there's some reticular pseudodrusen, some intermediate size drusen here. And yeah, there's nothing, when you look at the OCT angiography, we have a couple of little projection artifacts here, but no evidence of any lesion or vascular lesion. When you look at B, looks weird. We have what we call here choroidal excavation, a little area of focal choroidal excavation. Usually fairly benign, right? Could turn into something. Man, who would have thought on OCT angiography there was a little membrane there? Just kind of riding home the point here. I would have missed every single one of these, right? I consider myself pretty good at OCT and I just didn't see a problem here, but I did it because I was learning. On C, this is the little neon that I showed you before, the little double layer sign, the non-exudative membrane that had the little guy right there. So, hopefully drove home a couple of points here that this technology really can do a lot for us as far as making us better clinicians. I'm excited about it every single day. I know Dr. Major, we both love OCTA and find the value in it, but I'm hoping that you guys can look beyond reimbursement, look beyond, making money and think about just taking the best care of your patient and what this technology can do for you.